Okay, all right, so today on Road to 250, I'm going to talk about HIV, its infectious process, how to fit, and how the treatment options kind of make sense with the way HIV infects us. So to start with, just defining HIV versus AIDS. HIV is a virus that is attached to our immune system. And so, as the name says, human deficiency immune virus. And if the virus infection is not treated, it will proceed to or result in AIDS. AIDS standing for acquired immunodeficiency syndrome. And then CD4 cells are best used to follow the disease progression as HIV attacks CD4 cells. And remember, the role of CD4 cells they are our T helper cells, and they are going to signal other important cells to fight off foreign invaders in our body. So the transmission, essentially, we're looking at what are the different ways we can acquire HIV, and these are going to be mostly via contact with 3 types of body fluids. So, well, actually kind of 4, but the 3 major ideas are going to be blood. So this is going to be exposure to infected blood via needles, most commonly IV drug users, needle stick injuries in the health environment settings. Contaminated blood transfusion, which is really low risk since our blood is really highly regulated at this point. And then prevention of this would be proper anti-HIV medications. For example, if you had a needle stick injury at work or whatever. The next type of bodily fluid exposure would be sexual or genital. It is the most common type of transmission. And we're thinking vaginal fluid, rectal fluid, semen/pre-seminal fluid. In new infection, these fluids are highly infectious. So that is also why it's the most common mode of transmission. Anal sex unprotected has the highest risk as the mucous membranes are present in the area and they're exposed. However, the most frequent type of infection is vaginal sex, and that's also unprotected. So essentially, mucous membrane exposure is what you're really concerned about here in the sexual genital type of transmission. And then if you present or have a STI, it increases the risk of transmission as well. And so prevention of this type of transmission is going to be condoms. Breast milk is also a mode of transmission, especially in HIV-infected mom. She's going to transmit to the baby, and the baby is going to feed with those HIV particles that get transmitted through the milk. And there's not really a clear mechanism as to why those antibodies get transmitted in the milk. And then lastly, you can actually also have vertical transmission at birth, so during the birthing process. And then, so you do need to have, when you come in contact with people, it has to be via broken skin. So there has to be some type of broken skin. It does not get transmitted through air, saliva, tears, sweat, urine, feces, handshaking, or casual contact. None of those are going to be modes of transmission. And the primary infection usually presents as like a flu or mono-like symptoms with cervical lymphadenopathy, maybe some tonsils that are enlarged, some fever maybe, that are going to last for maybe a week or 2, and then they just get better on their own. And I'll kind of explain that in a little bit. So normally in our body, when we have foreign invaders crossing over the mucous membrane, we have things present on the mucous surface called dendritic cells. And these dendritic cells kind of have these protruding limbs that kind of stick out into the surface of the mucous membrane, and they sample the environment looking for foreign particles. So imagine this in mucous membrane locations such as the vagina, the rectum, etc. So once the dendritic limb detects a foreign particle, it's going to pull it into the mucous membrane, and then it's going to detect what type of particle it is. If the particle seems abnormal, the dendritic cell will then cut it up and display it to get rid of it. So it's going to display it or move it along. It'll take it into the blood and then distribute it to the lymphatics. So it's going to go to the closest lymph node available. So how HIV enters is via transmission in the lymph node. So the dendritic cell is going to detect this particle and it's going to say, this looks abnormal. We are going to take it into the blood and transmit it to the closest lymph node. And the process is called infectious synapse. And essentially, the dendritic cell latches on to the HIV particle, sends it to the lymph node, and hands it off to the T cell in the lymph node. The particle is then endocytosed, it's originally endocytosed and then exocytosed into the lymph. The HIV particle directly infects the dendritic cell even before it gets to the lymph node. So then you have like an infected dendritic cell making its way to the lymph node and exposure will occur. So that's kind of the general idea of how the initial response of exposure occurs. And you want to think that our lymph node is a location or area of, though it is going to be a place where things are broken down, the HIV particle is quite sneaky and tricky and will actually render the lymph node, I can't think of the word, but exposed, weakened to the HIV particle. Okay, so in general, HIV is a retrovirus, and so characteristics about the retrovirus. It's a single-stranded RNA-positive sense virus that gets turned into DNA via reverse transcriptase. It is an enveloped virus, and it does have, it is diploid in nature, and it contains 3 genes. The N gene, which is the envelope glycoprotein, which contains GP41 and GP120 that serve as a viral envelope, and together they make GP160. GP41 serves a purpose of being a role of transmembrane protein, versus GP120 makes up the outer glycoprotein. Then it has GAG, which is P24, and it's the capsule for the RNA strands. And then it has the polygene, which is polymerase or reverse transcriptase. So these are the things that the virus contains. That's what the virus has. These are the things that the virus needs in order to infect. So it's like its secret weapons. So the actual infection process. So again, remember we're in the lymph node that the HIV was brought to, or the particle was brought to the lymph node by the dendritic or macrophage. It infects, its idea is that it's going to infect the T helper cell. And okay, fine. This slide becomes a little repetitive, but that's okay. So the HIV particle is going to access the membranes of the CD4 cell. That's going to be particularly by the CD4 receptors, which are going to be CCR5 and CXCR4, which is a co-receptor. And the HIV proteins, these are specific to the HIV particle itself, has the GP120, which is going to interact with the CD4 receptors, the CCR5, CXCR4. And essentially, you want to think of it as a lock and key mechanism. So the GP120 binds to the CCR5 and binds the C. So once the binding occurs, there's a conformational chain, allowing then the co-receptor to also bind the CXCR4. And essentially, the 2 particles are now close together. So they're bound and come close together. And this part is kind of called fusion. And so the viral capsid is, and necessary particles are then allowed for CD4 to enter. So, okay. So here's a picture of the HIV particle, the GP120, the GP41. P17 is a matrix protein, but P24 is a capsid protein, which is going to be part of like the nucleus, if you will, of the HIV viral particle. And then the reverse transcriptase, which is inside, which is the key secret ingredient to making the RNA to DNA virus. Okay. So here in this picture, if you look closely to where my arrow is pointing, is the initial receptors. So here's a CD4 cell, and here are the receptors CCR5 and the CD4 receptor, and then CXCR4 in the blue, which is like the co-receptor. And then here, the bottom, you see the viral particle and the GP120 protein that will then become the lock and key mechanism with the CD4 receptor, which is the green, and the red, which is the CCR5 protein. This picture here is showing the fusion process. So once the lock and key mechanism occurs, which is the binding with the CD4 receptor and the CCR5 receptor, the viral particle creates a fusion with the CD4 cell, and the viral particles, which would be the reverse transcriptase and the RNA, can then be dumped into the CD4 helper cell. And yep, so that's going to be what this picture is exemplifying. And then next, this viral capsid that got dumped into the CD4 cell is going to degrade. And we're now going to start the process of reverting the RNA into DNA. So enzymes of the T helper cell are going to break down the viral capsid and release the RNA and the reverse transcriptase. And then viral RNA, so it's single-stranded, is going to turn into single-stranded DNA, and then viral DNA double-stranded. So essentially this process is going against what's essential, or it's going the opposite direction of our essential dogma. Instead of RNA to DNA, we're going, or sorry, instead of from DNA to RNA, we're going RNA to DNA. Okay, so then the next step, so now that we have our viral DNA, a protein called integrase is going to tag on to the double-stranded DNA, and it's going to transport it into the nucleus of the nucleus of the helper T cell. And then here, the integrase actually puts a cut, or cuts the DNA of the CD4 cell, and it's going to integrate our viral DNA into the normal T cell DNA. And so here you can see the viral DNA integrated into the normal CD4 DNA. And then from there, the cell will transcribe it like normal and create proteins. So from here, two things can happen. Either the latent period can take place in which nothing happens. The viral DNA will be integrated, but it will just kind of stay dormant, and that can occur up to 10 years. Or, like I said, transcription will occur, and proteins will be made and then get released into the endoplasmic reticulum to make the proteins for the machinery of HIV. So then these proteins get ejected out, and essentially they start expressing themselves on the surface of the CD4 cell. And they also make a thing called viral polyprotein. And essentially these little different colors are kind of representing the different machinery pieces needed to make HIV and replicate HIV. So like reverse transcriptase for the pink, and the DNA, and the protease, and the yellow piece would be the integrase. So those are all important pieces in order for HIV to move on to another cell and do the same thing you just did here. So once a viral polyprotein is made, essentially budding off is going to occur. And the budding off will occur by protease. Protease is going to bud it off. And this budding piece right here is going to be an immature HIV particle. And then once budding off actually occurs, it becomes a mature HIV particle. So then that gets released into the bloodstream to then infect other CD4 cells. So again, in words, once the CCR4 and CD4 receptor bind and fuse, it will the viral capsid will get degraded by the CD4 cell enzymes, and it kind of gives HIV the advantage here at this point, because our own cells are helping to expose the HIV particles to our own cell. And degrading that HIV particle that got dumped into the CD4 cell is allowing for release of the viral enzymes and RNA into the CD4 cell. And then the revert, so that's going to take the viral RNA and use CD4 enzymes to revert viral RNA to make viral DNA, and then replicate it to make viral double-stranded DNA. Again, it's the reverse of the central dogma. And at this period, lots of errors can occur because there's no proofreading polymerase to do that. And so this is important because it's why vaccines are impossible to make, because there's just going to be so many different strains of it. And then the virus can also, for this fact, become resistant to medications. After we have viral double-stranded DNA, the integrase protein will bind to that newly synthesized double-stranded DNA and carry it to the nuclear pore into the nucleus, and that's the point of no return. And it cuts the human T cell DNA and allows for integration into the CD4 DNA. This is where kind of there's two different fates. One, it could be the latent period where the integrated viral DNA will be there but not doing anything, or that viral DNA will get transcribed and then crank out mRNAs and ribosomes to make proteins, which is then released into the ER. And then the viral polyprotein is produced, which is a bunch of proteins such as integrase, RNA polymerase, etc., which needs to replicate viral DNA in the future. And then we have the immature particle, which is right before budding, and it has the viral polyprotein and the protease needed. And the protease eventually will cleave. The protease's job or role is to cleave that polyprotein to separate the particles, so then they can do their own jobs once they infect another cell. Okay, so the idea is that HIV actually will only kill about 5 to 10% of the immune cells, but actually 90% of the cells that are killed are just normal, uninfected CD4 cells. And the idea is that the infected cells, our body's going to realize or recognize the viral transcripts building up, and it's going to want to kill it off. So there is a thing called IFI 16, which is this role is to recognize foreign transcripts, and then it's going to cause immediate stimulation of the inflammatory cascade and cause self-destruction sequence because there's just this huge abundance of inflammation going on, and it causes pyropoptosis, so a type of apoptosis. There is another protein called DNA PK, which senses when the DNA break occurs. So this is what integrase does. And essentially it's caught and that will render the cell also to die, so it will cause apoptosis. And then we have caspases, specifically caspase 8 will activate and trigger a self-destruct sequence as well. CD8 cells will kill off infected cells by detecting the HIV receptor expression on CD4 cells, and will also cause death. So essentially what's happening is more normal CD4 cells get killed off, even if they're not infected, as a protection mechanism, because the body just thinks, oh my gosh, they're all infected, or the inflammatory cascade is affecting other cells. So not only is it causing inflammation to the infected cell, but then the other cells around it get affected as well and die off. And then there's also a loss of uninfected T cells. Okay. So HIV diagnosis, like I said, the initial symptoms are usually just flu-like, headache, sore throat, fever. And initially we can do a blood test. However, antibodies against the virus are only going to present months later. And that's usually the case, usually 2 to 3 weeks before antibodies can form. So it's kind of a disadvantage if someone comes into your office who has flu-like symptoms and it's just 1 or 2 weeks into their sickness and you don't really detect anything and you send them back home. But instead, they could have possibly have the infection. Also, you can look for bits of the virus through different tests. So meaning integrase, the P24 protein, and these bits of the virus that are important key players can be detected earlier than antibodies, as they're going to be there. But these are also only going to be present within the first 2 weeks. So if someone comes after that period, you might not really be able to detect these. But what we can do is double check. So we can do the ELISA, which is going to detect HIV antibodies or the P24 protein. And if it's negative, it means you don't have HIV. However, if it's positive, you're going to go on to do a subsequent Western blot detecting the HIV proteins, GP120, GP41, reverse transcriptase. So if you have a positive ELISA and you have a positive Western blot, you have HIV and it's confirmed. If you have a positive ELISA but a negative Western blot, it's almost certain that there's no infection. And if you have a negative ELISA, it's almost also a no infection unless you're in the window period. So that would be some of the ways we can diagnose HIV. Any questions or anything anybody wants to add on?
Not sure, but 2018 first aid said Western blot tests are no longer recommended. So I'm just confirming that right now.
Okay. It might be true. I wouldn't. I just kind of used sources of my old first aid book plus Sketchy Micro. So that could be very true. Maybe
you can continue. I'll come back to it. I'm looking it up. So I don't want to.
Okay. I think another way to do diagnosis is you can look for the viral load or the CD4 count, and that would be via PCR. And I think it's just important to keep in mind that the ELISA can give you a false negative if you do the test too early in the infectious period. So, and then the Western blot could be not a good test anymore. Okay, so the idea of antiretrovirals is they stop people from getting really sick. They reduce HIV levels to almost undetectable. So they are pretty good. And they decrease the transmission risk and keep the viral levels low. So the way I kind of ordered the antiretrovirals were in sequence of how the infection process occurs. So to start with the fusion process, we have fusion inhibitors. And these essentially bind to either GP120 or 41 and prevent HIV from binding to and entering the CD4 cell. So it sticks to the protein that HIV needs to get into our cell. Specifically, the CCR5, which is the Miraviroc, is also necessary for the HIV entry. So it's used to enter cells in the early stage, and hence why it makes it a good drug. So Miraviroc binds the CCR5 receptor on the cell surface of the T cell, and it inhibits the interaction with GP120, versus enfuvirtide binds to GP41 and inhibits the viral entry from there. Enfuvirtide has adverse reactions of skin reactions at injection sites. So it's anaphylaxis when you're administering it. The next drug is going to be the NRTIs. And this is the idea that reverse transcriptase uses viral RNA as a template to create single-stranded DNA, and reverse transcriptase has to use CD4 cells, nucleoside, to build the DNA strand. So the NRTI gets inserted like as it poses as a nucleotide, and it gets incorporated into the DNA by reverse transcriptase, and it halts further elongation. And that's because this NRTI that poses as a nucleoside has a missing component that's needed for elongation of DNA strand to occur. So all in all, it prevents double-stranded DNA from being formed. And then importantly, zidovudine is the best for pregnancy. It's actually the best all around in terms of pregnancy, meaning pregnancy, during labor, and postpartum, to reduce the risk of transmission. So not just during the pregnancy period, but it can be even after, even postpartum, for at least about 6 months. But in addition, we have the abacavir, didanosine, I'm not going to try to say that, lamivudine, stavudine, tenofovir. And the adverse effects of these are going to be bone marrow suppression, peripheral neuropathy, lactic acidosis, anemia, pancreatitis. And abacavir is contraindicated if the patient is HLA-B5701 mutation due to increased risk of hypersensitivity. That's something different. Okay. The NRTIs, this is going to be a drug that's going to target reverse transcriptase. So it's not going to allow incorporation into the DNA chain. So it inhibits reverse transcriptase is the whole idea. So inhibiting reverse transcriptase will inhibit the process of double-stranded DNA from being made. So these drugs are dilavirdine, efavirenz. Okay, I'm going to stop. And the adverse effects of these are rash, hepatotoxicity. You do get vivid dreams and CNS symptoms with efavirenz and dilavirdine, and that one are contraindicated in pregnancy. Okay, then the next step in the usual infectious process would, if we had made a double-stranded DNA, would be integrase, taking it into the nucleus, and then allowing for integration into the CD4 DNA. So integrase inhibitors, hence, will prevent virus being transported into the nucleolus, and also the step is major for cell self-destruction, which is saving our good CD4 cells. So these are the drug names, and as it says, inhibits GIV genome integration into the host cell chromosome, and the adverse effect of these are just increased creatinine kinase. And then last but not least is the protease. Remember, the protease protein is the one that was like the protein that will cleave. That's necessary for the viral replication to occur in further subsequent infections infecting CD4 cells. So these drugs all end in navir. So navir T is a protease. And The adverse effects are hyperglycemia, GI intolerance, lipodystrophy, so Cushing-like syndrome, nephropathy, hematuria, thrombocytopenia, frindavenir. And then rifampin reduces the protease inhibitor concentrations, so use rifabutin instead. So that would be all of the drugs used in the HAART therapy for HIV. So then I have questions for you guys. So a group of researchers is studying a new prevention opportunities for HIV infection. They focus on preventing HIV entry into target cells by blocking a specific protein. Blockage of which of the following proteins would be most effective in preventing HIV infection? A, the NEF gene product, B, TAT gene product, C, fibronectin, D, cadherin, E, CCR5.
E.
Right, exactly. E, since it's the only component that's even related to HIV particle. Okay. An infant is evaluated at the office after developing prominent oral thrush, interstitial pneumonia, and severe lymphopenia during the first year of life. The patient was born full term to a 25-year-old woman who received no prenatal care and is a IV drug abuser. She breastfed her son for the first month, but then switched to formula feedings. The mother is currently unwilling to undergo any kind of testing. She tells a healthcare provider, just take care of my son. Which of the following prenatal interventions would have most likely prevented this infant's condition? A, enzyme inhibitor drug, B, interferon therapy, C, killed vaccine, D, live attenuated vaccine, E, prenatal vitamins, F, toxoid vaccine, or G, viral component vaccine.
I'm guessing since we're talking about HIV,
A.
Yeah, exactly. Yeah, there's no vaccines, so any of the vaccines wouldn't be a choice, so that cuts C, D, F, and G. Prenatal vitamins aren't going to prevent HIV infection, and that's what the child is presenting with, which I guess, yeah, you can kind of also assume. Interferon therapy is not therapeutic for HIV, so enzyme inhibitor drug. Specifically, we're thinking dizidavudine, so that would be an enzyme inhibiting NNRTI. Okay, last one. A scientist is conducting research to discover novel drugs targets for antiretroviral agents against HIV. A blood sample from a 22-year-old man with HIV is being analyzed in the laboratory. Purified CD4 T cells are extracted. Using molecular tracing techniques, the scientist follows a viral HIV protein that is synthesized in the patient's T cells. She finds that the protein becomes glycosylated before being proteolytically cleaved into two smaller proteins in the endoplasmic reticulum and Golgi apparatus. Based on this data, which of the following describes the function of these two newly formed HIV proteins? A, viral DNA integration into the host genome. B, viral DNA synthesis from RNA template. C, viral polyprotein cleavage. D, viron attachment to the target cells. E, virus-induced apoptosis.
B.
D.
Which one did you say?
B for boy.
Okay. Divya?
D for dog.
D for dog. Okay, yeah, this one's tricky, and D is right. It's kind of trying to get you to think of the budding off process, if I'm not right. Yeah, before being proteolytically cleaved into two smaller proteins and above. Let me just pull up the. Okay. So in the HIV replication part, the polyprotein precursors are encoded by the structural genes. Only the polyprotein product, and so the envelope, which is the reverse transcriptase, is glycosylated to become GP160. So that's GP41 and 120 make 160. So GP160 is cleaved within the endoplasmic reticulum, and it forms a GP120 and 41. And then GP120 mediates viral attachment by binding to the CD4 receptor of susceptible cells. So for further infection. It's not the best answer, but explanation.
Well, it just sounds like if they're talking about something being glycosylated and then proteolytically cleaved, it has to do with the 160.
Yeah.
And if it's being cleaved into two products, it's the 120 and 41, and these guys have to do with attachment of the virus. So that'll give you that answer choice.
Viral attachment, because that's what the initial role of them are, and what it would be for future, for further infection, further infecting other cells. And that's all I got for you guys. I should also look up the whole. So in terms of diagnosis, that was Warner recommended, so that's not an answer choice anymore. Oh yeah, I forgot to mention this, but for babies, doing an antibody antigen screening test is actually not recommended, because in vertical transmission, that is actually what the mother passes on to the baby, is the antibodies that she has. However, it doesn't necessarily mean that the baby is infected. And so what you do want to test for in babies is actual for the proteins. So like the GP120 or GP141, reverse transcriptase, I don't think you can test that, but the P24, that's what you would actually test for. And you can do that via PCR. Is what I believe is the right. Yeah. Western blot makes more sense to me since it does detect proteins, but it's not indicated anymore. Or the other more indicated type of diagnosis would be the viral load or the CD4 count, which is done by PCR. Oh, another thing is in the AIDS defining process, AIDS is also defined either by a CD4 count less than 200, or if the patient has an AIDS-defined illness. So even if their CD4 count is not less than 200, but they still have an AIDS-defined illness, they are still considered to have AIDS. Any questions? Anybody confused? Hopefully that helped you out. I figured that once I was able to really understand how the virus infected us, the drugs became like that much easier. So it was kind of good.